Aortic dissection. Aortic dissections usually present with the chest pain. So what is the approach for the patient with chest pain or discomfort? So first of all, we need to see the patient is stable or unstable. What are the symptoms? Physical examination, ECG, lab works, and imaging. Physical examination. One has to examine and see the painful area. Is there any sign of trauma or any local pathology? Auscultation can give a murmur. So the general appearance may suggest seriousness of the symptoms. Vital signs: marked difference in the blood pressure between the arms suggest the aortic dissection. That is the hallmark for diagnosis. Palpate the chest wall. Hyperesthesia may be due to herpes zoster. Complete cardiac examination. Pericardial rub. Signs of acute aortic insufficiency or aortic stenosis. Ischemia may result in MI, murmur, and look for S4 and S3 gallops. Determine if the breath sounds are symmetric and if wheeze, crackles, or evidence of consolidation. Labs: look for troponin, CKMB, myoglobin. Imaging: the common modalities is obviously first of all we do chest X-ray, then CT scan and esophageal echocardiography and aortogram. The classification systems for the thoracic aortic dissection. So time is important, acute versus chronic, and anatomic. It could be ascending, descending, or both. Or there are two specialized classifications, Stanford and DeBakey. In Stanford, type A is involving the ascending aorta, type B is involving only the descending aorta, and DeBakey is ascending and descending aorta. Type 2 is ascending aorta only, type 3 is descending aorta only. So this is DeBakey type 1 classification, type 1, type 2, and type 3. The pathophysiology of acute aortic syndrome could include aortic dissection, intramural hematoma, and penetrating aortic ulcer. So after the dissection, there are two lumens seen in the aorta. One is the true lumen and the other is false lumen. The true lumen can be round or oval, strong systolic Doppler velocity, and thrombus is rare. False lumen is crescentic shape, sluggish or no Doppler velocity. Thrombus is common. Cobweb is 100% specific. So antegrade propagation, 60% in DeBakey type 1, 10% in DeBakey type 2, and 25% in DeBakey type 3. So dissection of the descending part of the aorta, which starts from the left subclavian artery and descend into the abdominal aorta. Aortic dissection occurs when an injury to the innermost layer of the aorta allows the blood to follow between the layers of the aortic wall, forcing the layers and they part. So the dissection beyond the left subclavian artery is the descending thoracic aortic aneurysm, and it can be classified as type B or type 3 of DeBakey. Retrograde propagation of type A. It can be viewed as retrograde arch extension that extend into the ascending aorta. Retrograde propagation of the acute type B dissection often manifests as a recurrent pain that occurs variable time during the hospitalization. Retrograde type A aortic dissection is defined as dissection that originates distally to the descending aorta with retrograde flap progression into the ascending aorta. The The classical aortic dissection, intramural hematoma, and penetrating aortic ulcers. So the demographics of the classic aortic uh, dissection: elderly male, hypertensive, marfanoid, bicuspid aortic valve pathology, pregnancy, symptoms severe and sudden, sharp chest or back pain, associated finding myocardial infarction, aortic regurgitation, stroke, syncope, visceral ischemia, and location could be ascending or descending aorta. Diagnostic features is intimal flap separating true and false lumen. So the risk factors for aortic dissection is hypertension, age, connective tissue disorder, Marfan syndrome, pregnancy, aortitis, male gender, decelerating trauma, iatrogenic trauma, bicuspid aortic valve, and cocaine use. So this is a table showing the sensitivity of the clinical history in the diagnosis of acute thoracic aortic dissection. So these are various studies which has been done, and the history of hypertension as outlined is 64, Marfan syndrome 5, and any pain is 90, back pain 22, abdominal pain. So there is a degree of variation in the type of presentation and sensitivity of these pain. And sensitivity to physical examination. So as outlined, pool sensitivity is around 49 for the elevated blood pressure, diastolic murmur around 28, pulse deficit 31, pericardial rupture 6, and congestive heart failure 15. Sensitivity of the chest pain, it's chest plane radiograph. So abdominal aortic contour 71, and with a confidence interval 95% confidence interval, and pleural effusion 16, and displays intimal calcification 9, and widened mediastinum 16, and abdominal chest radiograph is 90. And this is the positive likelihood ratio and the negative likelihood ratio of the accuracy of the clinical finding for thoracic aortic dissection in consecutive patients pre-selected for highly clinical suspicion of aortic dissection. These are various studies which are compared. So history of hypertension, sudden onset of chest pain is important, and the tearing or ripping pain is the next thing. Then migrating pain, pulses deficit, and enlarging aorta. Majority of the data is derived from the retrospective chart reviews. Significant selection bias falsely inflating both sensitivity and specificity. They do not reflect the contemporary practice. Lower threshold to the scan with the 64 MDCT triple rollout. History: the most patients with a spontaneous thoracic aortic dissection have severe pain for the abrupt onset. The absence of the pain or of sudden onset substantiatively decreases the probability of dissection. However, the study design of the reports precludes the accurate assessment of the sensitivity and specificity of these changes. Physical examination: pulses deficit positive, LR 5.7, 95% confidence interval 1.4 to 23, or focal neurological deficit positive, LR 6.6, greatly increases the likelihood ratio of the thoracic aortic dissection in appropriate clinical setting. Presence or absence of diastolic murmur is not useful. with the likelihood ratio of 1.4 and negative likelihood ratio of 0.9. Chest X-ray. A normal aorta and mediastinum on the chest radiograph helps to exclude the diagnosis. The negative LR 0.3, 95% confidence interval, zero point 0.2 to zero point 0.4, but no particular radiographic abnormality is dependably present. Clinical history examination and radiography can help to rule out the aortic dissection, but are not sufficiently accurate to rule out this disease. Main complication: 30% get the ischemic complication. In type 1, mortality due to complications increases 1% per hour. Etiology: dynamic obstruction, occlusion of the true lumen by false lumen, static obstruction by compression disruption thrombosis. The main complications that can happen is tamponade, acute severe aortic insufficiency, MI, CVA, spinal infarct, paraplegia, aortic rupture, mesenteric renal limb ischemia, and pseudoaneurysm. Acute severe aortic insufficiency, there is widening of the sinotubular junction causing improper coaptation, diastolic leaflet prolapse from the detachment of the aortic leaflet, commissural attachment, intimal prolapse. Murmur is typically heard over the right sternal border. Acute MI occurs in 5% of the type 1 dissection, usually involves right coronary, often present as a complete heart block or inferior right-sided MI. Mortality, if you thrombolize, approaches 70%. Neurological complications, CVA, 10% of type 1's, carotid occlusion, 5 to 10% of dissection present with syncope. Spinal complications include intercostal arteries, artery of Adams-Quick, and can recover if treated early. Chest X-ray sensitivity of 60 to 70% and specificity of 70%. Chest X-ray findings include widening of mediastinum, 63% of type A and 56% of type B, double shadow of the aortic wall, disparity of the size in ascending and descending aorta. Imaging modalities, transthoracic, transesophageal, CT, and aortography perform better in high-risk populations. Aortography sensitivity and specificity is 94% and specificity is 94% and sensitivity is 88%. Pros: identify the site of origin, branch artery involvement, aortic insufficiency, and coronary extension. Cons: lengthy, large dilute, and expensive, invasive, and may fail to identify intramural hematoma. CT sensitivity is 83 to 100%, specificity is 87 to 100%. Probably even better with newer generation of helical multi-slice scanners, and accuracy may approach around 100%. CT can identify the intimal flap, branch vessel involvement, extent of dissection, false lumen patency, aortic size, pericardial effusion, and end organ ischemia. Non-invasive cons include the contrast material cannot detect AI or visualize the coronary artery dissection. Sensitivity is 95 to 100%, specificity is 98%. Pros: less nephrotoxic, gadolinium, non-invasive, excellent visualization. New techniques allow fast scan times 4 minutes. MRI cons include lengthy availability and metallic hardware and difficult to monitor. Echo transthoracic sensitivity 77 to 80%, specificity 93 to 96%, flows fast, inexpensive, available. Cons operator dependent, can only evaluate the aortic root and arch and distal ascending aorta and descending aorta, not assessed. Low sensitivity. Echo transesophageal sensitivity is 100%, and specificity is 95, flows rapid bedside tests. Cons cannot visualize abdominal aorta, sedation is required. Relative contraindication, chest trauma, varices, strictures, tumors. There is a blind spot, the right main stem bronchus obscures the visualization of part of ascending aorta. So dP upon dt, the change in pressure per unit of time is important, and if there is a higher change in pressure, that's not good for aortic dissection. Negative inotropy, and thus the rate of rise of blood pressure as well as the mean and peak systolic pressure. The negative chronotropy, the fewer peak systolic pressures for vulnerable vessels to experience. Alpha blockade to prevent the compensatory vasoconstriction. Goal blood pressure as low as possible without inducing organ failure. Systolic blood pressure of 100, MAP of 60 to 70. No great evidence this would be a tough population to ethically randomize. Pharmacologic options with invasive monitoring, esmolol, beta blockade, bolus and infusion 1 mg per kg, and labetalol alpha antagonist properties. 20 mg IV bolus may require up to 80 mg over 10 minutes. Propranolol 1 to 10 mg bolus followed by 3 mg per hour. Nitroprusside, beware of cyanide toxicity. Do not use without beta blockade as there is a reflex tachycardia. ACE inhibitors may be used, but given the high risk of renal failure and unreliable gut function depending upon the course of dissection, they would not be plan A. For patients who cannot tolerate the beta blockers, non-DPH calcium channel blockers, verapamil or diltiazem are very viable option. If open communication with aortic root, then pressure rises quickly as a result of PEA, and pericardiocentesis is likely to be useless. But not everyone dies, so blood in pericardium leaks back through a false lumen. Communication in some cases is transient, stopped due to thrombus or intimal flap. As tamponade increases, the pressure gradient between the false lumen and the pericardium decreases, which results in stasis and thrombus formation. Tamponade also compresses the ventricle, decreases the blood pressure, and dP upon dt, which reduces the propagation of dissection. So pericardiocentesis by releasing tamponade, there is increase in BP, dP by dt, which can worsen the dissection. Increase the gradient between the false lumen and pericardial space, which may release the thrombus or flap and result in an open communication with aorta. Both results in PEA, which usually is not recoverable. If stable, go to OR as soon as possible. If unstable, there is an option of pericardiocentesis, but people still recommend to take to theater. So ascending aortic dissection is a surgical emergency. Mortality 90% at 2 weeks if untreated, non-surgically managed. Most common cause of death is the initial registration of AA dissection, acute aortic dissection with aortic rupture and visceral ischemia. Contraindication is stroke. Relative contraindication considered about the transformation into hemorrhagic stroke with anticoagulation and reperfusion. So delayed presentation 48 to 72 hours can optimize clinical condition prior to surgery. And there's a Kaplan-Meier curve showing the operative repair 10-year survival as illustrated for the patient undergoing the operation equivalent of the group A to group B. Prior AVR can operate semi-electively, protect against AI. Dissection cannot cross a suture line. And RCA is protected by suture. Adhesions decrease the chance of free rupture in pericardial sac. Contraindications and comorbidities, age, ARF, shock, redo surgery. If high-risk surgery, could consider the medical management. So this is a graph comparing the survival after the onset of dissection. 10-year post-dissection survival is stated for all the patients as a function of whether they underwent operative repair, black line, or the medical management, gray line, and there is a trend towards the improved survival among the patient undergoing the operative repair. Indication for intervention in type B, persistent chest pain, involvement of the side branch of compromising vital organ perfusion, impending rupture, rapid aortic expansion, peri-aortic hematoma, hemomediastinum. Endovascular intervention, the branch vessel stent placement, percutaneous aortic balloon fenestration, aortic stent placement, stent graft placement over the intimal entry restores the normal blood flow in true lumen and induces the thrombosis of the false lumen. Indications for PAF, mesenteric ischemia, renal failure, severe renovascular hypertension, paraplegia, and severe peripheral ischemia. Treatment algorithm, medically stabilize the patient, confirm the diagnosis of dissection, define the location, ascending aorta, surgical candidate, yes, surgery, no, medical management, descending aorta, clinical status is stable, medical management, unstable surgical candidate, no, endovascular surgery. Complications following thoracoabdominal aneurysm repair, pulmonary complications, there could be renal complications, neurological, spinal cord injury, cardiac complications, and reoperations for bleeding, GI ischemia, GI perforations, and other causes. Respiratory failure, although there is continued focus on the spinal cord ischemic injury and postoperative renal failure, the postoperative respiratory failure remains the most commonly reported complication. In the main published series, the multiple etiologies, lung isolation, post-thoracotomy, diaphragmatic injuries, phrenic nerve injury, and TRALI and ARDS. Renal failure, pre-Aiken and RIFLE classification. In one analysis, the aortic cross-clamp time more than 100 minutes was the single intraoperative variable associated with postoperative renal failure. Intraoperative hypotension for more than 10 minutes trends towards the significance and regard to post-op renal failure, but was only significant in association with perioperative death. Patients who experienced post-operative renal failure had approximately tenfold increased risk of perioperative death. Neurological events. The spinal cord injury of any sort remains one of the greatest fears after the thoracoabdominal aneurysm repair. Spinal cord injury is divided into the immediate deficits and delayed deficits. The delayed onset of deficit continue to occur in 10% of the patient, and although these are often partial and reversible with acceptable functional outcomes, and continued vigilance to the perioperative care, especially the avoidance of hypotension. Thank you. Cardiovascular event. The cardiovascular complications occur in 14% patient, and myocardial, it includes myocardial infarction, arrhythmia, CCF, unstable angina, and management according to standards should be done. Paraplegia. Try to correct, at least limit the amount of ischemia to the cord by increasing the MAP and decreasing the spinal ICP. Increased MAP till neurologic recovery is seen, or limit the MAP reached safe upper limit of MAP defined by the surgeon, volume resuscitation, transfuse as needed, liberal use of inotropic support, especially with neurological shock, may require high doses. Lumbar CSF drain, ICP goal of 8 to 12, cap 12 to 48 hours, remove at 36 to 48 hours.